contacting us about HIPEC. I guess a lot of our referrals come from the medical oncologist once we see, or a surgeon that sees cancer in the peritoneal cavity. I think it's prudent to reach out to a surgeon or a center at least that does these operations, and that they can assess whether it's appropriate disease, appropriate patient, appropriate, and all the staging and stuff is appropriate to have that evaluation or not. They are complex decisions, and I think they are best done at high volume centers or centers that do these.
And I would add two things here, Glenn. So number one, we would like to be involved as early as possible in the care of these patients. It is not uncommon, for example, that we will get called from a surgeon in an operating room 2 hours away, and they incidentally find these tumor deposits or this mucin or jelly and ask us what to do. And almost routinely, our answer is just to stop so that we can ask them to get some tissue so that we can see what it looks like under the microscope, and then have a more multidisciplinary approach. And to that point, I think the second important recognition is that oftentimes these patients are treated with a combination of chemotherapy and surgery. And what is often the discussion, and depends on patient factors like Nabeel said, when their last operation was, what the tumor looks like under the microscope, it is not infrequent that we suggest giving 3 to 6 months of IV chemotherapy first prior to surgery. And sometimes we say, yes, doing surgery now or in the next 2 weeks is the most appropriate thing, but that is a very tailored approach. And so we, as the surgeons, who typically this is a surgical disease rather than it is an IV chemotherapy disease, but that's not to say there's not a space for IV chemotherapy, but we'd like to get involved as early as possible and have a multidisciplinary plan set forth so that either us or the medical oncologists aren't getting involved 6, 9, 12 months after the diagnosis is made. That's frustrating for everybody.